I'd encourage you to have a look at it. I'm really grateful to the sponsors, to the endorsing national societies who we've all met, SEPAR, Sanofi, Regeneron, who have been very generous in their distribution of grant money that was unrestricted, and we're deeply grateful to them for this. And now on to the important topic, ventilation. This is a key area and one I think that we're all going to learn a lot in.
Absolutely. ERS offers world-class courses and conferences in the field of ventilation. The Respiratory Failure and Mechanical Ventilation (RFMV) conference was launched by ERS in 2020 and takes place every 2 years. The event brings together a diverse mix of leading respiratory scientists, clinicians, and allied healthcare professionals for a comprehensive 3-day program. For the 2022 conference, registered participants can access the replay, and ERS members can access the sessions via the e-learning resources website. The next RFMV conference will take place in 2024, with more information coming soon. We hope you can join us. Okay, so now let's dive into the heart of this session. We will start with a talk by Professor Peter Calverley. I don't think Peter needs an introduction, but still he deserves one, definitely. Peter is a highly well-known, renowned expert in the field of COPD and ventilatory failure. He's a professor of respiratory medicine at the University of Liverpool, and he will give us a talk on the mechanisms and bedside assessments of in the field of ventilatory failure. So Peter, very nice to have you with us. The floor is yours.
Thank you very much indeed, Nicola and Richard. It's good to be here, and I'm glad to be speaking about this. I'm getting old these days, so they've given me a topic which is vaguely contemporary with me, because much of what I'm going to say is information that's been available in the public domain for some time. Although the title's ventilatory failure, I'm actually going to be talking about respiratory failure because I've widened that in view of the following talk. So we're covering quite an area here. I do not have any conflicts of interest. I'm hoping I'm going to be able to change this slide, but I seem to be hung up at the moment. Yeah, there we are. I've nothing to disclose in this context, and I hope that, yes, it's rather slow responding is the problem. Could I have the next slide? Thank you. sort of ventilatory system, the lungs, an area for diffusion where blood and air can intermingle, a transport system to the tissue, and of course then, once you get to the tissue level, diffusion to the mitochondria. And that is effective and it works very well, and we're going to focus, being respiratory people, on ventilation. So let's consider some useful definitions and some equations that might be helpful in understanding that. Successful gas exchange can be defined as an arterial oxygen tension of 13.3 kilopascals, 100 millimeters of mercury, and a PCO2 of 5 kilopascals, approximately 40 millimeters of mercury, when breathing room air under conditions of normal acid-base balance of pH of 7.36. Hypoxemia of any importance, type 1 respiratory failure, occurs when the PO2 falls below 10 kilopascals, but the CO2 stays normal. And hypercapnia when the PO2 is below 10, but the PCO2 is above 5.5. Let's consider some simple physiology that underpins that. That CO2 tension depends upon the amount of CO2 the body's producing and the alveolar ventilation, production versus clearance. Alveolar ventilation is itself a feature of encompassed by minute ventilation plus dead space. And you can rearrange that equation relatively simply, even for someone like me, to show that alveolar ventilation is dependent on the ratio of the dead space to the tidal volume. And so the lower the tidal volume, the smaller the alveolar ventilation and the higher the PCO2. This is why breathing pattern is so important in the determination of gas exchange, and particularly ventilatory failure. If you want to look at alveolar oxygen tension, by contrast, you should consider that that's the difference between the inspired oxygen concentration and the arterial CO2. You can then calculate the alveolar arterial oxygen difference, much used in intensive care medicine. Now, that's the PaO2, which you can calculate, and minus the arterial oxygen tension. It would be nice to easily calculate the shunt fraction as well, so that you could work out how much of the blood is missing the lung. That does involve measurements of arterial, venous, and end capillary oxygen tensions, and is really difficult to do outside the ICU. These abnormal blood gases, because I should just pause a moment and say that all of this theory was blood gas measurements back in the 1960s. And as a result of that, we now have been able to create a whole adequate theory. Inspired oxygen concentration can be reduced, as in at altitude, or if for some reason there's an obstruction to breathing, for instance, in an endotracheal tube. The main pulmonary factors are VQ mismatching, alveolar hypoventilation, to a lesser degree diffusion limitation, and rarely AV shunts. Extrapulmonary factors include increased oxygen uptake, often forgotten, but it can happen in thyrotoxicosis, where you lower the mixed venous PO2. A low cardiac output, again operating by the same factors, and that is a common exacerbating feature in lung disease, and reduced pulmonary capillary transit time. All of that list relate to developing a low oxygen tension. But hypercapnia really depends on having hypoventilation, whether in an absolute or a relative level to the metabolic demands, or ventilation perfusion imbalance. Hopefully, the next slide will come. This is the 3-compartment model used by Riley and Cornon, or developed by Riley and Cornon, and that's nearly 70 or 80 years ago that they did this. And it basically shows that you can work out the amount of oxygen inside the alveolus by considering a variety of circumstances. If there is no perfusion, but plenty of ventilation, the oxygen's high, but the CO2 is very low. Conversely, if there's no ventilation, but perfusion continues, then based on that model and the careful calculations and graphical analysis that they conducted, I'm not sure why. Yeah. It was possible to develop more complex analyses. This was the one most famously done by Peter Wagner and Roberto Rodriguez-Rosan, where you could plot the ventilation perfusion ratio distribution across the lungs. And normally in healthy lungs, it's near perfect. It's near on 1, which shows that under normal conditions, ventilation and perfusion are extremely well matched. If by contrast you consider what happens in disease states, which on the next slide should appear, you will see that, here we are, that in COPD, the top right-hand corner of the slide, you will have a lot of shunted blood, as well as rather excessive ventilation. You've got a mixture of 2 problems there. Contrast that with asthma, but the main problem in acute asthma is a low shunt. So you can now analyze in some detail the causes of this using this model of ventilation perfusion imbalance. If you go on, however, and consider the implications of this, low VQ units contribute blood with a low PO2, and that cannot be compensated for by high VQ units. Low VQ units can eliminate more CO2, but also contribute to dead space, so that actually, conversely, can promote hypercapnia. Mixed venous PO2 is important and often forgotten as a factor leading to a low oxygen tension. The implications of gravity are relevant. It's different if you're lying down or sitting up, and you can develop a patent foramen ovale, which can certainly contribute to shunting. All of these, of course, rely on analysis of ideal alveolar oxygen, but that's not necessarily what happens in life, and it also assumes to remember that ventilatory failure can be episodic or sustained, acute or chronic, and the implications of that are considered in the next few slides, if I can get them to come up in a timely fashion. I like these data, which come from a new study by Harbert and et al., published this year in the ERJ, where they are actually able to measure in real time the VQ relationships in single breaths and calculate the true alveolar oxygen, arterial oxygen gradient and the alveolar arterial CO2 gradient. They did this who'd had COVID-19 infections, where we know gas exchange is severely deranged, and where you can see here, when you plot the PaO2 against the PaCO2, that the red dots, who are the unhealthy COVID patients when they're sick, have very abnormal gas exchange indeed, and that when analysed further, is a mixture of increased dead space, increased shunting, and a combination of the 2 factors, which gradually resolves over time, but not necessarily completely. Now, next, we should see what happens and the importance of intermittent hypoxemia overnight. These are patients who have Duchenne muscular dystrophy. And here you can see that the CO2 tension relates to the months of survival. If you've got a high CO2 tension and you have Duchenne dystrophy and weak respiratory muscles, you are quite likely to die early. But also, if your oxygen saturation at night dips in these patients, although it doesn't persist into the daytime, that is a bad prognostic feature. So intermittent respiratory failure can be important clinically as well in certain settings. Events, and you get a classification which looks something like this. On the right hand side of the slide, you have the type 1 respiratory failure, which, as I say, can be acute, and that may be due to localized problems like pneumonia or a pulmonary embolism that we talked about this morning, or it can be more diffuse, as in ARDS or cardiogenic shock. Alternatively, COPD, asthma, and diffuse interstitial lung disease can all lead to persistent hypoxemia. If you look at the left-hand side of the slide, you see the issues of hypercapnia in normal, not just intrinsic lung disease. There are other factors that are relevant. And those include sedatives, upper airway obstruction, which I've mentioned during the night, and neuromuscular disorders. And hopefully, yes. This is a way of analysing the ventilatory failure more specifically. It really belongs to the concepts developed by John Moxham and co-workers that focuses on the crucial role of the respiratory muscle pump. Here you can see there's a balance of load and capacity. If the muscles are weak, and that can happen intrinsically, or because they're not operating effectively due to hyperinflation, or if they're overloaded because there's a heavy load of airflow obstruction, or ventilation's increased, then that will affect the balance. And if that balance favors ventilatory failure, and if I can guess, there we are, but other inputs, particularly for chemoreceptors, are important. And remember that if you increase the PO2 when somebody has respiratory diagnostic implications, though, because your ability to successfully use NIV is certainly related to your mental state. Central cyanosis has been the clinical hallmark of these problems, but it's influenced by lighting conditions, and particularly with modern strip lighting, is hard to detect. It's generally more obvious in polycythemic patients where the hemoglobin concentration is high. A flapping tremor can be detected, so-called CO2 narcosis, reflecting that cerebral edema I was referring to, but again, it's very non-specific and occurs in other conditions. Objective assessments for the bedside are relatively limited and do depend on the setting. You can certainly do more in the way of objective assessments in an intensive care unit than you can on a general ward. But even then, you're still perhaps more limited than you'd like. The key measurement is pulse oximetry, reflecting the importance of the oxyhemoglobin dissociation curve. It's ubiquitous and useful, but it's really complementary to, and not a replacement for, arterial blood gas tensions. You've got to be cautious if the circulation's poor, because you will get an erroneous SpO2 reading, and sometimes carboxyhemoglobin levels when high can be problematic, though modern oximeters tend to adjust for this. You aim for a 90 to 93% oxygen saturation. You've got to be aware of CO2 retention, as I said, at higher inspired oxygen concentrations, particularly in the context of ventilatory failure. Sudden decreases in oxygen saturation may mean actually not that the patient's deteriorates, but it's still a valuable way of monitoring patients. And it's really suitable for both continuous and remote home monitoring, and that's why it's become so popular. The cartoon on the right shows the fact that the dissociation curve is influenced by other factors, by temperature, by the pH, by the concentration of 2,3-DPG. But in general, although perhaps not the most precise tool, it's still very valuable. The biggest limitation is that the SpO2 doesn't tell you anything about the CO2 tension, and you still need blood gas tensions to do that. What other assessments have we got that are potentially valuable? Pulse and blood pressure are probably underused and frankly understudied. Respiratory rate ought to be a valuable bedside measurement, but we are very bad at recording it, and many factors determine respiratory rate, not least the lung mechanical derangements of the condition from which the person is suffering. Transcutaneous CO2 has a relatively slow response time. It's quite good in stable ventilatory failure, but it's not really good for extended periods of monitoring. Spirometry and inspiratory capacity measurements have been made as an indirect guide to the severity of disease, but are influenced by the abilities of the patient to cooperate. We should get lots of useful information from non-invasive ventilation, but they are influenced by the quality of the mask fit and its degree of synchrony with the ventilator. Ultimately, there's no substitute for repeated arterial gas measurements in sicker patients who are getting better, and in those with comorbidity or a low initial pH. In future, more extensive use of minimally invasive physiology like oscillometry might be a valuable way of taking things forward. And there are, if I can get to it, some data which tell us that oscillometry can work in the home setting. The CROMED study, funded by the EU, looked at 302 multimorbid COPD patients around Europe. By measuring oscillometry on a daily basis, it was intended that it would allow the patients to be monitored. And we could detect changes in respiratory system resistance and reactance. The primary outcome was the time to first hospitalization. And in this analysis, it was possible to show in subgroups of patients that you could use this system, monitoring at home using these oscillometric variables, to detect patients, particularly those with heart failure or those who had been hospitalized in the previous year. You could reduce their risk of subsequent hospitalization, although this didn't affect their exacerbation rate overall. And if this. So, well-established physiological models provide good explanations for the mechanisms that underlie ventilatory failure. VQ mismatch and alveolar hyperventilation predominate, but extrapulmonary factors shouldn't be forgotten. Ventilatory failure can be transient or sustained, acute on chronic, or chronic. The underlying mechanisms fundamentally remain the same. COPD, neuromuscular disease, and sedative drugs are major factors leading to ventilatory failure, and high inspired oxygen concentrations in those at risk of hypercapnia can decrease this. Clinical evaluation identifies very severe disease, but is often limited, and as you've seen on the screen for some time, bedside monitoring relies heavily on pulse oximetry, but other techniques do show promise. So thank you very much for listening and for coping with my technical difficulties. I'm more than happy to take any questions and clarification.
Peter, that was fantastic. Thank you so much. We'll be back to you to ask questions, but that was great. Our next speaker, following on from Peter, is Martin Dres. Martin is an associate professor at the Sorbonne University and a staff physician in the ICU at the Salpêtrière Hospital in Paris. He's going to talk on the respective roles of high flow and NIV in treatment of ventilatory failure. welcome, and the stage is yours.
Thank you very much for the introduction. Welcome everyone. It's really a pleasure to be here, and I really would like to thank the Committee of Organization for giving me the opportunity to be there and to discuss the respective roles of high flow and an IV in a patient with acute respiratory failure. So there are my disclosures. So the questions we are going to discuss are the use of non-invasive respiratory support, high flow nasal oxygen, and an IV in two different settings of acute respiratory failure. First, the acute de novo, mainly hypoxemic respiratory failure that are pneumonia and ARDS. And the second, the acute on chronic respiratory failure, mainly hypercapnic, such as exacerbation of COPD, acute cardiogenic pulmonary edema, or obesity hypoventilation syndrome. And of course, we could discuss during a long time about all these two diseases and the use of non-invasive respiratory support. And just to have a brief description of the indication, this is what I would suggest to look at. First indication would be to use the non-invasive respiratory support as a preventive treatment of intubation, which means that patient may have a respiratory failure with hypoxemia, but no intubation criteria. Second, alternative to intubation. So here, patient may have a respiratory failure with criteria of intubation, but the use of non-invasive respiratory support could be considered as an alternative to intubation. So there are the two main indications I'm going to discuss today, because I won't have the time to discuss the pre-oxygenation settings and what happens after extubation as a way to prevent the post-extubation acute respiratory failure. So, of course, I'm sure that everyone is well aware of what is a high-flow nasal oxygen device, but just briefly to summarize, we have an active humidifier, of course, because the idea is to provide some comfort to the patient. So here we have the possibility to the patient through the heated inspiratory circuit. And there is also a flow meter, which is something that we can use to set the amount of flow that we want to provide to the patient, from, let's say, 10 liters per minute, but up to 70 and sometimes 80 liters per minute. And besides the flow meter, there is the air oxygen used to set the FiO2. And it is possible to provide FiO2 from 21%, of course, if we don't use oxygen at all, but up to 100%. And one of the main interests of high-flow nasal oxygen is to saturate the air that is given to the patient in order to avoid any dilution of the air that is breathed in. And this air could be the air of the ambient air, the air from the room. So with this system, we are sure to guarantee a certain level of FiO2, and this is clearly a great advantage of the technique. And of course, we need an interface between the machine and the patient, and this interface here is not a mask like an IV or an endotracheal tube. It's a cannula that are put directly in the nostrils. And I think it is also important to keep in mind that we have to set the cannula and with taking into account the size of the nostrils of the patient in order to improve the tolerance and the comfort of the patient during the treatment. So what are the mechanism of action of high flow nasal oxygen? I don't have the time to cover all the mechanisms, so I just can recommend the reading of this narrative review published just a couple of years ago. So of course, because we provide some humidity, adequate humidity, we will improve the comfort of the patient. In addition, because we perfectly know the level of FiO2, we know that we will guarantee high level of FiO2, which will be translated into high level in PaO2 to the patient, which will have also a very good benefit, as we will detail later on. And there is another benefit, that is to wash out the dead space of the patient, which would provide some CO2 clearance that again will be a clear benefit for the patient. And last, the device can provide a certain level of pressure, in particular if the patient have their mouth that is closed. And this certain level of pressure between 2 centimeters of water, 3 centimeters of water can be translated into an increase in end expiratory lung volume, but also increase in terms of lung recruitment, in terms of lung compliance, which will be translated with the increase in PO2, the decrease in CO2, in terms of decrease in respiratory drive. That is something that we can clearly see in our patient when we use high flow nasal oxygen, with a decrease in respiratory rate. And altogether, it will be translated into a decrease in the work of breathing and into the decrease in respiratory effort. So probably the most important study that if we don't have a lot of study to discuss today, but if there is one to discuss, this is the Florali study. That was the first study to compare the use of high flow nasal oxygen in the setting of acute hypoxemic respiratory failure, and to compare this device to NIV and to standard oxygen. So here we are talking about acute hypoxemic respiratory failure, so mainly patients with pneumonia. And as you can see on the right side, the whole population, 310 patients with a median of PO2 and FiO2 ratio was 150. And despite there was no clear difference between the three groups, NIV, oxygen, and high flow nasal oxygens, in terms of cumulative incidence of intubations, when the investigators look at the most severe patient, the subgroup of patients with a PO2 and FiO2 ratio lower than 200, there was clearly a benefit for high flow, with a much lower and significantly lower incidence of intubation as compared to standard oxygen and to NIV. And we can also see that actually NIV was a treatment that was associated with a higher risk, higher rate of incidence of intubation. And I think this is an important concern that we should discuss at least briefly today during this session, because there are some benefit and some risk associated with spontaneous effort during acute respiratory failure. And it is important to talk about spontaneously breathing patient. The work of breathing is generated by the respiratory muscle. So the pressure inside the thorax is negative, minus 8 centimeters of water on the left side. This is what you can see on this slide. And because there is no pressure generated by any ventilator, the transpulmonary pressure, that is the pressure that distends the alveoli, is of an amount of 8 centimeters of water. In a normal anesthetized paralyzed patient on mechanical ventilation, here also the amount of pressure is very similar, because there is no pressure generated by the respiratory muscle, but there is pressure from the ventilator. But the problem is that if you have a patient with spontaneous effort and an IV, for instance, that will provide some pressure during the inspiration, here you have to sum the pressure that is generated by the respiratory muscle, here minus 15 centimeters of water, because the patient has a marked respiratory distress, as we can see during acute respiratory failure, plus the pressure inside the alveoli, that is the pressure provided by the NIV. So at the end of the day, the total pressure, the total transpulmonary pressure is much higher. It is 25 centimeters of water, which is something that could be concerning in terms of ventilator injury, in terms of lung injury or ventilator-induced lung injury. So this is clearly an important concern, which lead to discuss the concept of patient self-inflicted lung injury. Because during pneumonia and any kind of initial lung injury, because of the lung edema, because of the initial lung injury, of course, there is some impaired gas exchange or impaired lung mechanics, which will be translated into an increase in respiratory drive from the patient, which may generate high inspiratory pressure because the muscle, the respiratory and this will be translated into high tidal volume, which may create and may worsen the initial lung volume, initial lung injury. This is the concept that has been called patient self-inflicted lung injury, because here there is a kind of vicious circle that is created. And we have some indirect evidences of the effect of, or maybe of the harmful effect of NIV during acute respiratory failure, de novo acute respiratory failure. This is a study here that compare the percentage of NIV failure of patients who were treated by NIV for de novo acute respiratory failure, and the patients were separated according to the amount of tidal volume as expressed as milliliter per kilogram of ideal body weight. So plus higher 9.5 milliliter per kilogram of lower than 9.5 milliliter per kilogram. And as you can see, there was clearly a difference between these two categories of patients. Patients with high tidal volume during NIV were associated with a much higher risk of NIV failure. So this is clearly indicates that during NIV, we cannot guarantee to keep the tidal volume limited, as we should do when we ventilate patients with a lung protective ventilation in ERS, which is clearly a concern, because if the tidal volume are not guaranteed, there is this risk of NIV failure, which provides saw earlier the risk of PSILI through the increase of the increased tidal volume. And actually, we have another study that is an ancillary study from the Florali study that also suggests this, indirect evidences, because here the investigators had a focus on the patient treated with NIV. Remember, in the Florali study, patient receive either NIV or high flow or standard oxygen. But when they looked at the patient treated with NIV, they found that the tidal volume measured at H1 after the initiation of NIV, when it was higher than 9 milliliter per kilogram of predicted body weight, it was also associated with NIV failure and intubation, which is something very consistent with the So these two studies and the concept of PSILI clearly suggest that NIV could be harmful during acute respiratory failure if it is not possible to guarantee low level of tidal volume. Additional evidence that spontaneous effort could be harmful during acute respiratory failure. Here, this is one example, but there are some others of a cohort of patients with acute respiratory failure from COVID-19 disease. In this cohort of patients treated with non-invasive respiratory support, you see that 4%, which is not zero, but it's still a significant percentage of patients develop pneumomediastinum, and for the authors, they suggested that it was a surrogate of patient self-inflicted lung injury as an effect of the use of non-invasive respiratory support. So, still in the COVID-19 pandemic, I also wanted to discuss this study that compare, as the Floralis study, CPAP, high flow nasal therapy, and standard oxygen, according to the outcome of the patient in terms of intubation. And maybe you know the findings, but I will go through that very briefly. So the patients were randomized to receive CPAP, high flow, or standard oxygen. Intubation was clearly and significantly lower in the group of patients with CPAP. So it's not NIV, it's a CPAP, of course. So it is an interesting result. There was no difference for high flow and standard oxygen. Please note that there was a high rate of crossover in the standard oxygen group. So it may explain that the data are difficult to interpret, probably. But the problem is that this rate of intubation that was lower in the CPAP group was not translated into a better benefit in terms of mortality at the end of the day. So let's move now to see what says the international recommendation on NIV during acute respiratory failure. So it is a statement from the ERS in 2017. And as you can see, the panel was not able to offer any recommendation on the use of NIV in the setting of acute respiratory failure. And regarding the use of high flow nasal oxygen, they suggest to use high flow over conventional oxygen therapy, and probably acute hypoxemic respiratory failure. So let's move now to the use of non-invasive respiratory support in acute and chronic respiratory failure, so mainly acute exacerbation of COPD. I will be more brief here because a lot of things have been said already, but very briefly, it is well established that NIV can compensate the presence of intrinsic PEEP, during acute exacerbation of COPD. And there is also a very good effect on the respiratory muscle because it will allow to unload the respiratory muscle. So at the end of the day, it may provide a decrease in the work of breathing. And it is well established that of course, you know this very first study in the setting. It was conducted by Laurent Brochard in the 90s. And in this very first study, physiological study, NIV was associated with a short effect on the improvement of gas exchange in terms of pH and in terms of PCO2, sorry. And I also wanted to highlight one important point on the use of NIV during acute exacerbation of COPD. This is a study by Alexandre Demoule that highlighted a very important point, that is that NIV failure is not associated with an increased risk of death. That is not the case for de novo acute respiratory failure. So it means that in a patient with acute exacerbation of COPD, or more largely patient on chronic acute respiratory failure, it is always possible to do a trial of NIV, even in patients with hypercapnic encephalopathy, for instance, and to see if it is possible to reverse the encephalopathy. And if it is not possible, and at the end of the day, the patient is intubated, so there is a NIV failure, this is not associated with an increased risk of death. So it is clearly an important message. So a lot of studies have been published on this setting of the use of NIV in acute exacerbation of COPD. We know that it is very well efficient on intubation, but also on survival. So it is a clearly important message that lead to this statement, the same statement from the ERS and ATS on the use of NIV. And as you can see, NIV during hypercapnic with COPD exacerbation and cardiogenic pulmonary edema was associated with a strong recommendation for its use. So regarding the use of high flow nasal oxygen, we have much less evidences at this step. We have some physiological studies that are very interesting. For instance, this one that showed some physiological effect of high flow during acute exacerbation of COPD with a decrease in PCO2, decrease in respiratory rate, but we don't have yet a large randomized controlled trial showing that it is possible to use high flow nasal oxygen in these settings. So if we look at what says ERS clinical practice guideline that was published last year on the use of high flow nasal oxygen in hypercapnic respiratory failure, you can see that the experts suggested a trial of NIV prior to use high flow. So clearly, NIV is a first-line treatment to be used in this setting. So this is my last slide, which just to briefly summarize what we have to know yet. On chronic hypercapnic respiratory failure, NIV has to be used in first line, and high flow nasal oxygen may have some several advantages. And for instance, it could be used between hypoxemic respiratory failure. High flow nasal oxygen is an interesting and clearly efficient treatment over NIV CPAP on first line, but we still should be concerned on the risk of delaying intubation. Thank you very much for your attention, and I will be very happy to address any question.
Thanks a lot, Martin. Very clear, very nice presentation. Now we are going to move forward and listen to Anita Simmons, who is honorary consultant and Professor Emeritus of Respiratory and Sleep Medicine, working at Royal Brompton Hospital and also the National Heart and Lung Institute, Imperial College London. Anita, it's great to have you with us today, and we are listening very carefully. You're going to address the ventilated patient beyond ventilation.
I am. Thank you very much indeed, Nicola. I'm very glad to take part, and I've learned quite a lot so far. So I'm going to focus predominantly on the chronic ventilatory failure patient to complement what Martin was talking about. I don't have any conflicts of interest related to this presentation. The specific title is Beyond Ventilation, which sounds something rather like it's out of Star Wars or Star Trek, or continuing after a time or event. I'll also discuss discontinuation and weaning from ventilation, like it's a recent observational study, large study. Then talk about what's new in home ventilation, what's happening with prevalence internationally. I would like to talk specifically about palliative care in this. And so the use of this technique is particularly helpful in the adult intensive care unit and the pediatric intensive care unit, come to that, to improve secretion clearance, mainly in patients with neuromuscular disease and for acute use, of course, in the intensive care unit, but it may be useful in other prolonged weaning patients, those with a critical care neuropathy or myopathy, and to avoid intubation, to clear secretions and use in conjunction, say, with non-invasive ventilation in a patient with neuromuscular disease. It can also help facilitate extubation to aid that patient continue to clear their secretions. And as we'll come on to discuss, it can be used long-term in conjunction with non-invasive ventilation, often as an option, an alternative to invasive mechanical ventilation. And I'm showing you this algorithm here because there's some interesting work that's been done just to provide pathways for management of the acute patient. Of course, the context is extremely important here. This is an individual, and we're using it in an individual who has got a weak cough, and often in the situation where you might suspect there's a large sputum plug there, or I've seen this used successfully to clear aspirated food. And in this kind of emergency situation, in that context, then of course there are quite a lot of considerations. Is the airway patent? Is the patient breathing? But if the answers there are yes, and the cough assist device used in this emergency situation can be extremely effective and may help you avoid intubation. For longer term use of the device, and this is predominantly in neuromuscular patients, this is a kind of, I think, way of understanding the sort of cough assist processes that are helpful, considering the vital capacity of the individual and also the peak cough flow. You can see as the patient gets weaker, the lower the vital capacity, the lower the peak cough flow, you can use more intensive assistance. And at these low levels, below around 270 litres per minute cough peak flow, that person may have problems clearing secretions in acute infection, but in other situations where there is more preservation of the cough, then other methods such as lung volume recruitment, manual assisted coughing can be used and then combined in the more severely affected patient. If you look at the settings required, so in these devices, there's no one best device, but this just demonstrates the kind of pressure and settings that are used. On average, you can see that the pressure settings, inspiration, the white bar, expiration, exhalation, the dark bar, on average, between different conditions, spinal muscular atrophy, Duchenne patients, ALS patients, on average, not much difference. But usually in all patients, the exhalation, the negative pressure you require is higher than the insufflation pressure. It is important to titrate the individual and some of the more complex patients to manage especially those with, say, motor neuron disease, have bulbar problems, it's still possible to improve their cough peak flow in this situation. And this is some of the nice work done by the Norwegian group with Tina Anderson. Here you can see showing that with this algorithm, you may need to fine tune the settings, reduce the insufflation pressure, increase the time of insufflation, or even remove exsufflation to optimize secretion clearance in these patients. But if you do that, and you don't have to use laryngoscopy, of course, in all patients, this just helps you understand what works best in principle. So I'm going to move on from ventilatory adjuncts to talking about weaning in general. And I picked this rather nice, large observational study, which has been published in the last couple of years by Karen Burns and her group, looking at what's happening internationally with weaning practices. This actually surveyed 19 countries, so across US, Canada, Australia, New Zealand, many countries in Europe, including the UK. And what she demonstrated is a number of interesting findings. Of course, the majority of patients who are on the ITU and being weaned from invasive mechanical ventilation have either acute respiratory failure or they're post-operative patients, but there was a significant subgroup who had acute on chronic respiratory failure. And what did she see? What are the take-home messages? Well, the first thing to say is this observational study, comparing and contrasted with similar studies done, say, 10 years ago, actually does show an improvement in outcomes, although, of course, the outcomes are not as good as you see in randomized controlled trials where you have selected cohorts of patients. Of all the patients overall, you can see between a fifth and a quarter were extubated directly, and about a half of them had spontaneous breathing trials, in which about 80% of those are successful. Not surprisingly, if those who required a spontaneous breathing trial compared to those who were extubated directly had a worse outcome, these are likely to be and were because those patients had more comorbidities. And if you had a failed spontaneous breathing trial, your mortality was twice that if you had a successful trial. What they did show, though, is they tried to examine the use of written directives and protocols. What it's clear is, despite a lot of guidelines over time, that there is still very substantial variation in the use of protocols and the use of written directives, how one carries out spontaneous breathing trials. You use TPs, you use CPAP, the use of different ventilatory modes of weaning, roles of different clinicians. Some interesting findings, though, which I think are notable, are that, and perhaps not surprisingly, is according to sedation scores, the more highly sedated patients fail their spontaneous breathing trials, and there seemed to be a relationship of that to sedation protocol. So having a sedation protocol and weaning that down may be a way of reducing failed spontaneous breathing trials. Now, that's withdrawal from invasive mechanical ventilation. As we discussed in the last presentation, many of our patients are now receiving non-invasive ventilation. And how do we withdraw that from patients? Well, a significant number can be withdrawn directly, especially if they've had a short period of ventilatory support. Then there are other ways of gradually decreasing the level of support, either decreasing the duration of non-invasive ventilation, reducing the time they spend on the ventilator during the day, tailing it down to nighttime use and then off at night, or decreasing the level of pressure support, or perhaps a combination of those. And I think we're seeing more frequently now sequential use or alternating use between non-invasive ventilation and high flow nasal oxygen in this acute on chronic patient group. And that may be particularly helpful pragmatically after patients have been decannulated. Do we have any evidence as to what is the right technique to use or the right process to use? This is an interesting study where they took patients having used NIV for an acute exacerbation. Either they withdrew the NIV straight away, direct withdrawal, or they tailed it down to nocturnal use first. You can see in this cohort of patients there was actually no difference in 6-month survival in those who the NIV was withdrawn directly, or in those it was continued for a period at night. This is an Indian study where they had an either direct withdrawal, or they reduced pressure support, or they reduced the duration of ventilation. In fact, there was a slightly better outcome in those where they tailed it, the pressure support or the duration of ventilation, but this was a very short study over a matter of hours over a longer period of time. And I think what we really need to think about is the different phenotypes of these patients that we're considering. In those last 2 studies I showed you, they had similar FEV1s, but we know even amongst those patients there are different phenotypes. And here, this was a study again looking at patients with an acute exacerbation. The NIV was withdrawn at the end of the period. They were sent home off non-invasive ventilation. In that group, they had a similar survival time, but contrast that with the HOT HMV study. This was a group of patients who actually remained hypercapnic for at least 2 weeks after the overt recovery from their exacerbation. In those who the hypercapnia was protracted over that period, they had a much better outcome in terms of admission-free survival by continuing on home mechanical ventilation. So I think this important clinical consideration is very crucial in understanding what patients need to continue on ventilation at home and the way we discontinue it. What about trends in home ventilation? Well, this is quite interesting, really. This is a recent publication showing trends over the last 20 years in prevalence of ventilation. So this is per 100,000 patients. This is Norway, and a very substantial increase in prevalence over the last 20 years. Then we have some more sort of gradual increase in say, Netherlands, Spain, Germany, UK, and then other countries you can see here, USA, where the increase is much slower. And why should that be? Some broad relationship between gross domestic product, so level of financial status of the country, this sort of line of identity. You can see Italy, Croatia, Denmark, Germany, UK, pretty much on there. But there are other countries where there are quite substantial deviations, a high prevalence of home ventilation in France, high prevalence in Norway, a high income country. And then you can see other countries, US, Australia, high income countries, relatively speaking, but the prevalence of home mechanical ventilation is lower, significantly lower. And the explanations for these are very interesting, because we all pretty much work from the same guidelines. We all use the same indications. There's even one of the factors that explains this is actually the coordination of care and the enthusiasm for home mechanical ventilation in practitioners in those countries. Just want to mention briefly another interesting finding from France. This is looking at home ventilation in patients with slowly progressive neuromuscular disease. So these were patients, about half had Duchenne muscular dystrophy, others had limb-girdle muscular dystrophy, previous polio, so not patients with motor neurone disease. About 2/3 of them were on tracheostomy ventilation. The quality of life in the majority, but there were some interesting findings comparing the tracheostomy and non-invasive ventilation group. Actually, the tracheostomy ventilated patients had less breathlessness while speaking, while eating, and also at rest and during exercise than some of the patients using non-invasive ventilation. And these were broadly comparable groups of patients. So I think it makes us rethink the option of tracheostomy ventilation at home, although clearly there are a number of considerations, including the level of home support that is required in tracheostomy ventilator dependent patients, and also the level of sort of cough assist support that's also provided to both those groups of patients. A quick point on nutrition as well, since we're talking about holistic care. It actually affects the quality of life, and particularly in patients with motor neurone disease. I think it's possible we sometimes wait to put in a peg or a rig rather late in the process, but it's clear here that generally, if patients are losing weight as opposed to maintaining weight, it has a significant adverse impact on quality of life in virtually all the aspects of this SF36 score. And I thought it worth adding this nice reflective paper here on symptom palliation and emotional well-being and distress in ALS patients. Of course, levels of distress can be very high for obvious and understandable reasons, but we can play our part here. And one particularly important contributor is feeling unsupported by professionals, the care system. And the more we can support these individuals in their ventilatory care and all the other holistic aspects of care, the better the outcome will be. It's a Norwegian study that's also shown really matters to patients. And I would suggest that if you're a respiratory support service that is not providing this level of support, you're not really a service. A point too on our patients are living longer with some conditions. So these are Duchenne patients. Bernkrandt drew attention to this issue a long time ago now, showing that patients are now living longer and developing problems that they didn't live to the age to develop previously. Quite a lot of complex bowel problems in Duchenne patients, problems with renal bladder calculi, nutritional problems, as we've mentioned, new and different orthopedic problems, such as large joint issues, problems with contractures and pain control, different sorts of cardiac complications, not just heart failure in some of our neuromuscular patients, but complex arrhythmias. And underlying many of these problems can be autonomic dysfunction. And we shouldn't neglect the psychological and emotional aspects. And all of this indicates that long-term symptom palliation needs to be. Just going to finish here on the increasing use of outreach, virtual care, the ability to obtain data from our patients at home, physiological data and data from their ventilator, so we can remotely change settings. Clearly, this has been enhanced considerably during the pandemic with virtual wards. That's one of our remote clinics. It's interesting, there are clear advantages to this, many advantages, but there are also limitations. And some of our patients that have been having remote follow-up have requested to come back into the clinic because they miss face-to-face care. So the balance needs to be absolutely there. But we can clearly assess the efficacy of ventilation and solve problems if we see desaturation at home. And finally, I want to make the point that follow-up is crucial. This is a 5-year follow-up study showing how ventilation of patients, because if there is residual hypoventilation, which is well demonstrated using capnography, that residual level of hypoventilation can lead to ICU admissions and reduce event-free survival. So has a really adverse effect on patients. And so to emphasize the importance of follow-up. So with that, I will finish. Thank you very much indeed.
Anita, thank you very much. There's loads of questions that we're going to follow up with afterwards, but that was a fantastic lecture and a great overview of this really challenging area. Our final speaker in this session is Alexander de Mol. He's the professor of intensive care medicine at the Sorbonne University, and he is going to talk about horizon scanning for ventilation. Alexander, thank you so much for joining us. We're really looking forward to your presentation.
Thank you very much. Thank you very much for the invitation. Thanks to the scientific committee for having invited me to give this talk on horizon scanning. So what is horizon scanning? To me, was giving you the perspective. So what is the potential future of mechanical ventilation in acute respiratory failure? So here are my conflicts of interest, my disclosures, all in the field of mechanical ventilation. So I chose basically 4 topics. First, helmet non-invasive, then CPAP, which is back, and we don't know about the future, and phrenic pacing to a Hassan winning. So first, let's start with helmet non-invasive. When we treat a patient with acute respiratory failure for respiratory cause, obviously in some case, we will intubate the patient as the first line treatment. This would be the case if we have a patient with acute de novo hypoxemic respiratory failure with, for instance, coma or a shock. But in other cases, patients with flu pneumonia or pneumonia of other cause, then we can try to prevent intubation. And we have 4 tools. We have standard oxygen, high flow, nasal cannula, CPAP, and non-invasive. And unfortunately, what we have learned from most studies is that non-invasive is not so efficient in this setting. And as Martin Dress told us, the last guidelines from ERS and ATS concluded that in acute de novo hypoxemic respiratory failure, given the uncertainty of evidence, it was unable, the panel was unable to offer a recommendation on the use of non-invasive. It doesn't mean that non-invasive is disrecommended, but just because in de novo acute respiratory failure, the failure rates of non-invasive is very high. And second, the problem is that the mortality of patients who fail non-invasive is extremely high. And third, one of the reasons why patients, why non-invasive is not so efficient in de novo acute respiratory failure is that it may contribute to patient self-inflicted lung injury. And Martin Dress, in his talk, explained to us what is this, the risk, what is this patient self-inflicted lung injury, but by the high level of pressure that non-invasive delivers combined to high inspiratory efforts, there's a high risk of patient self-inflicted lung injury. So an alternative would be to use the helmets. The helmets may decrease the high level of external pressure delivered by the ventilator. And in the COVID, there was this very interesting trial from the Massimo Antonelli groups in Italy, led by Grigo. It was 109 adult patient with severe COVID and run invasive plus high flow or high flow. The primary outcome was 28-day respiratory support, 3 days. And unfortunately, in terms of primary outcome, the study was negative, but among secondary outcomes was the risk of intubation. And you can see on this Kaplan-Meier graph that the intubation risk was reduced in the helmet group. Of note, mortality was not different between the two groups. So there might be something interesting here in the helmet, and the helmet could be an interesting tool in the future. So another interesting tool is CPAP, and I think that we can say today that CPAP might be back. So CPAP, I said, is another tool to prevent intubation in acute de novo hypoxemic respiratory failure. Why is it interesting? So in acute respiratory failure, we have alveolar filling, surfactant abnormalities that lead to collapsed lung. So with CPAP, of course, we give a better FiO2, which improve alveolar pressure in oxygen, but also we give PEEP. And we give PEEP that with first improve FRC and decrease shunt, and so contributes to reduce hypoxemia, but we also improves lung mechanics because it will improve compliance and then unload respiratory muscle. So both the reduction of hypoxemia and unloading of respiratory muscle will reduce respiratory failure. And we don't have the high inspiratory pressure that we have with the non-invasive, the bi-level non-invasive. So this could reduce the risk of patient self-inflicted lung injury, reason why it is quite interesting. So in terms of evidence in the COVID, we have the nice recovery ERS randomized study, the 102,033 adults with severe COVID randomized to receive. Primary outcome was intubation or mortality within 30 days. And what we can see from these Kaplan-Meier graphs is that there was a significant reduction in the intubation rates in the CPAP group as compared to standard oxygen. However, mortality was not reduced. But we see that we have a potential here. Third strategy is prone positioning that it was implemented during the COVID. So you can see awake prone positioning led by Stefan Hermann was more than 1,000 patients included over 6 different countries. Patients were severe COVID patients, and it was COVID, all patients received high flow, and randomization was awake prone positioning versus standard of care. So severe COVID-19, high flow for all patients, and then awake prone position versus no awake prone position, primary outcome. Here that regarding intubation, there was a benefit of awake prone positioning since the intubation rates was lower in the awake prone position group as compared to the standard care group. However, this did not translate into a reduction of mortality. Very interesting. The results suggest that here you have the proportion of treatment failure in red as opposed to treatment success in gray. And on the x-axis, the mean duration of prone positioning in hours. And what you can see is that the proportion, the number of patients with treatment failure was dramatically reduced in patients who had more than 8 hours of prone positioning a day. So it seems that the technique is particularly efficient if the patient receives at least 8-hour prone positioning a day. So it's not like giving 1 or 2 hours prone positioning, it's 8 hours at least, if we want to see a benefit. So in this horizon scanning talk, one last perspective, which is phrenic pacing to Hasson winning. So it has been demonstrated years ago that mechanical ventilation may induce diaphragm dysfunction. So we see here the force frequency curve of diaphragm muscles. And we have on the y-axis the force as a function of frequency. We see here a normal diaphragm in a spontaneously breathing animal. This is not a patient here. And if we expose animals to mechanical ventilation, we see that there's a clear reduction in the force that may produce the diaphragm. So mechanical ventilation induces diaphragm dysfunction in animals. It is also well evidenced in humans. And this is true for diaphragm, but not for limb muscles. Mechanical ventilation induces diaphragm dysfunction, but no, not limb muscle dysfunction. So what has been shown in humans by Martin Dress, actually, in a study from our group, is that patients with diaphragm dysfunction have a higher rate of difficult weaning and a higher rate of plunged weaning. So this suggests that it would be of the highest interest to treat or prevent this diaphragm dysfunction in mechanically ventilated patients with the goal of improving the proportion of patients exposed to prolonged weaning or difficult weaning. That is in as much the case that the total duration of mechanical ventilation is higher in patients with diaphragm dysfunction. So one option would be to stimulate directly the diaphragm, sort of diaphragm training. This is possible with years, phrenic nerve stimulation requiring invasive techniques because electrodes had been were implanted with surgery, either directly in the diaphragm by laparoscopy or around phrenic nerves by thoracoscopy. More recently was developed a catheter that you can introduce in the subclavian vein or actually also in the internal jugular vein. This catheter is equipped with electrodes that will be put in front of the 2 phrenic nerves, and that can stimulate phrenic nerves. So in animal work, we have here 3 animal, control animal with no mechanical ventilation, no pacing, an animal that has been exposed to mechanical ventilation, but no pacing, and the third animal exposed to mechanical ventilation with phrenic pacing. You can see that in the control animal with no mechanical ventilation, no pacing, we have a nice diaphragm fibers without atrophy, and then as opposed to animals, mechanically ventilated without pacing, we have atrophy. But if we pace the diaphragm of animals, it prevents atrophy. there's a potential here to prevent atrophy with recently in France and Germany, in which 110 patients were randomized to receive either standard of care or standard of care plus diaphragmatic nerve stimulation with transvenous catheter. You can see that in the group who received transvenous stimulation of the phrenic nerves, there was no improvement in terms of weaning, but that there was an improvement in terms of maximal inspiratory pressure. So to conclude this talk on horizon scanning, my first message is helmet the safe way to deliver non-invasive? Maybe. I find this is interesting. CPAP warrants future trials for sure, but this is another way and that we could use in the future to treat de novo acute respiratory failure. Awake prone positioning seems beneficial, but give it for at least 8 hours, and transvenous phrenic nerve stimulation may be beneficial in prolonged weaning. This is only the beginning. Thank you very much for your attention.
Thank you very much, Alexandre. You have in mind, and we are going to follow the same order as before. So I will start with Bernardino. Bernardino, what are the questions you would like to ask to whoever you want?
Okay, thank you, Nicola. I would like to ask Professor Cavalli 2 questions. One is about the role of race and ethnicity in the pulse oximetry measurements. For sometimes we were not aware, but actually with the COVID-19 pandemic, there was some papers in JAMA suggesting that Black people could have underdiagnosed respiratory failure due to false pulse oximetry measurements. Okay. And what is your thought about that? And the second questions I would like to ask is about the measurements of the PCO2 and pH during mechanical ventilation or non-invasive mechanical ventilation. It's well established, at least I think in Spain, not to make arterial punctures every time you need to know about the pH and the PCO2. So we go to venous samples. Is that correct? Is it correct to transfer the results from venous pH and PCO2 to arterial pH and PCO2?
Thank you very much for both of those very astute questions. I think that they are very relevant. Let's deal with the ethnicity question first of all. You're quite right. And I had intended to say something about that in my limitations of pulse oximetry, but I omitted that from the slide. There's a growing body, particularly in North America, of people who are ethnically Black who have problems with underestimates. Now, this is a very politically sensitive issue because it seems as though you're discriminating against one group. It also reflects to some extent the way the algorithms were originally set up. I suspect it would be perfectly possible to make adjustments for that if the manufacturers seriously put their minds to it. And that will be equal to people who were Black compared with people who were white. And I think that is work that needs to be done. But yes, there is a difference. It comes under the same sort of concerns that I raised about poor peripheral perfusion. As far as monitoring pH, yes, there's a long tradition going right back to the time before arterial blood gases were available of looking at venous PCO2 and potentially venous pH as a way of monitoring things. Clearly, the more direct measurement is to make arterial values. I think it is not desirable in NIV settings to have an arterial lining if you can possibly avoid it. It changes people in a much less intensive setting if you don't have to manage an arterial line. So the use of venous pH should be reasonable. The one caveat that one's got there is it's much better to follow a trend and perhaps to anchor it to an arterial pH at the outset and then see how it evolves. But yes, I'm aware of the Spanish data and I'm impressed by it. As yet, as far as I know, it's not the Spanish centers.
Okay, that's very clear answers. Thank you, Peter, for these, and thanks, Bernardino, for the question. Now we're moving to Cindy. Cindy, any question you would like to ask?
For these very clear and very instructive presentations. Are there contraindications for high-flow nasal cannula oxygen therapy in COPD exacerbations? And I was in particular thinking about patients with reduced levels of consciousness.
Yeah, thank you for your questions. It's clearly a great and very important question. The fact is that currently there is no indication for using high-flow nasal oxygen at the acute phase of acute exacerbation of COPD. And as I showed earlier, recommendation said that we should use NIV as a first line. So I think what could be relevant with high flow is to use it between NIV session. And the question, your question regarding the status of the patient, the neurological status of the patient is clearly an important question, but as far as I know, we don't have enough of evidence to suggest one strategy over the other one. So I think that as long as we can monitor the patient and the patient has received NIV as a first line, I think it is clearly reasonable to high-flow nasal oxygen has a washout effect, in particular on the CO2 removal. So, which is a good reason to use it and try to improve the neurological status of the patient. So this is what I would say. Yes, between an IV session, but clearly not at the very acute phase in the most severe patient, the patient with respiratory acidosis.
Okay, thank you. Very clear.
Yeah, thank you, Martin. Maybe, Martin, if I can follow up on this. How would you do that in reality, in practice? Alternating high flow NIV, do you have any specific protocol in terms of the duration of the high flow session between an IV and an IV between high flow, or is it a feeling, or do you have any objective measurements that you will be relying on?
No, it's a very relevant question and practical question. So my simple answer is to say no. I don't have any kind of protocol, but I think we can discuss together and maybe suggest some tools. So clearly, the first line is NIV, and in our experience, we know that in some patients, sometimes it is difficult to maintain an IV for prolonged duration session. And we don't want any, we don't want the effect of the FiO2 actually. So I think for the patient who are who develop intolerance to the NIV, using high flow after or instead a session of NIV could be a good opportunity. But I think the tools or the surrogate that we could use for the assessment of the tolerance as the respiratory rate, which is a very good marker of the respiratory drive. So clearly, this is something that we should monitor and keep an eye on the respiratory rate of the patient, and also the neurological status, because of course we just don't want to keep the patient too long drowsy, and if should then proceed to intubation.
Okay, thanks a lot. That's clear. Florin, your turn. I'm sure you have questions.
Yeah, of course. Thank you for this board eye view concerning ventilation. My question is referring to the exposure of our Professor Simons, Anita. It's a question with two parts. First of all, I know in some countries it is this practice of winning. Very curious if there are if there are very evident some cost benefits concerning using this type of winning in some specialized units, and what is the influence on mortality if we are practicing this transfer of patients from mechanical ventilation in winning units.
have labored breathing, not very important, not marked at least, and they do not complain about dyspnea. So the usual criteria for intubation do not work properly in COVID patients. And as you said, many COVID-19 patients who obviously had admitted criteria for intubation were not intubated and eventually improved. So I think that what is difficult is to find the right balance. Intubating too early patient with the COVID is not a good idea because it will increase too much the patients that intubated, and actually we wouldn't have the adequate number of beds to manage those patients, and probably we would intubate patients who do not need intubation. But on the other hand, we should not delay intubation. And for instance, I haven't shown you those data, but we have data from our group and other groups that suggests that postponing intubation after 7 days is probably very deleterious. So early intubation is not a good idea. I would say wait and see. There is no good criteria to predict or to identify patients who really need intubation. But I'm also saying that we should not push too hard. And we all have seen those patients. So we wait 4 days, 5 days, 6, 7, 8, 9, 10 days. And then after 10 days, we intubate the patient. And then the patient is very severe, with very low compliance and extremely severe. So we should not wait too long. I would say that patients who remain very severe after 6, 7 days, I'm not sure it's a good idea to continue. I hope I have answered your very difficult question.
Thank you. Thank you so much.
Thanks, Nicoletta. There's been a lot of questions come in on the chat line, and I don't know if we'll get to them all, but I think we'll certainly come back to most of you because there's some great, very practical questions. Peter, I'm going to ask you first because this question popped in. It was pretty much the first question that came up, and it was that that old chestnut, I guess, that people often ask, which is in the COPD patients and some of the other folks who get too much oxygen in the emergency department or in the ambulance on the way to hospital and who develop a worsening of the carbon dioxide. What's the thinking as to how that comes about?
There's been two main theories. I suppose I put them under the hypercapnia in red on one of my slides. Are you worsening alveolar hypoventilation? Are you increasing VQ mismatch? There was work back in as long ago as 1980 that suggested perhaps, at least in French patients who got to the ICU in France, that VQ mismatch was the major factor. But other work in non-intubated, non-ICU patients has suggested that they are actually, relatively speaking, hypoventilating when you give them oxygen. You can actually show that their minute ventilation drops with oxygen as their CO2 goes up. In other words, they need that excessive alveolar ventilation to clear the CO2. And on balance, it's probably in most circumstances, it's an impact on peripheral chemoreceptors, peripheral carotid chemoreceptors, and you are abolishing hypoxia drive when you give very high, and people do give sometimes very high levels of inspired oxygen. And you've got a fair idea that that's important because when you take it away, then that problem tends to correct itself. And there's been plenty of examples. I think it has got a little better since we introduced targets for oxygen for people coming in ambulances. That's the 93 to 96% I referred to. But you used to see people coming in with saturations of 100% and PCO2s that were rapidly climbing and pHs falling to 7.2. which needed NIV to correct it, which was clearly undesirable for the patients and a dangerous situation. So I think it's mainly hypoxic drive. I think in some settings, especially if there's background consolidation, in alveolar consolidation, you're more likely to get a bit of VQ, but a hypoxic drive is still the favored mechanism.
Thanks, Peter. That's it's great to hear those thoughts. Martin, there was another question that came in, and I thought it was an interesting one. It was when you're weaning high flow nasal oxygen, do you have thoughts on whether we should be reducing the flow rate or the oxygen? Which would you do first in this chicken and egg situation?
It's a tricky question. I think what is clearly stay stable is a good way to go and to proceed further to the weaning from high flow nasal oxygen. So I would say that if we are between 30 and 40% of FiO2, it is time to try to decrease the flow and then to try to match the patient demand and then to go to, for instance, a face mask or something like that.
That's great. Thank you. Alexander, there's a question that came in on the helmet, and it was really more around what's your view on where you see this technology? If you were to design the ultimate study on helmet technology, where do you think it's really got its role?
So the helmet is mostly used in Italy. And the use of helmet is not so high in other countries. To me, the interest of the helmet would be to add helmet session on the top of high flow. So we consider a patient with severe acute hypoxemic respiratory failure, de novo, so COVID, flu, and then we give high flow, and we would add helmet session on the top of this, but prolonged session, I would say at least 16 hours a day. And that would be the intervention arm of the trials I would design if it was possible, if I had the money for that.
And actually, talking about endless amounts of money, just briefly, would you speculate on tools? Peter said how bad bedside monitoring was, and we were all struggling to answer the question that you were struggling to answer, which is the great question of when do you intubate? So could you speculate for us as to what you'd love in 10 years' time of tools to monitor patients at the bedside?
Me, at the bedside?
Yeah.
What I would dream of is a tool to detect dyspnea in non-communicative intubated patients. This is the tool I would like for monitoring, because I know that this is an unrecognized cause of suffering. And if you ask me what I would like to have is this.
That's a fantastic observation, and one that you do sense in the ICU, that there may well be a great suffering. And there's some amazing technologies being done on direct monitoring of brainwave patterns. I'm wondering if that's where you think that solution might arise.
Yes, it might. It might be from recording treatment of EEG signal, for instance.
Yeah. Peter,
that's one of the options.
Peter, in terms of bedside monitoring, Peter, you had a question, but I'm...
sorry, ask your question, Richard, and I'll give you the answer, because I think we have got closer to that desirable aim than we sometimes recognise.
Which is?
which is, I think, actually, there's quite a lot of work, mainly out of the St. Thomas's group, on parasternal EMG. Now, clearly, that's going to be influenced by what else you do with your patient, and if you've got somebody who is spontaneously breathing, parasternal EMG is relatively easy to manage, relatively susceptible to automation, and it will give you a good idea of what respiratory drive is. I don't think there's a single EEG variable that will tell you about breathlessness, and indeed breathlessness is multifactorial, as you see if you do functional MRI. But if you want to know what the drive component of it is, how much difficulty your patient is having to breathe at that minute, parasternal EMG is a good starting point, and one which I think ought to be taken up and studied more widely.
That's great. Alex, what's your thoughts on this?
Regarding the drive?
Yeah.
Yeah, I think that if we want to improve the measurement of the drive in non-intubated patients, this is probably from the EMG that we get, like, yes, from the EMG for measuring inspiratory drive is probably the most promising technique.
That's great.
In intubated patients, we can use PO1, but in non-intubated patients, EMG.
Well, that's really helpful, and thank you for the two of you for bringing that to our attention, and also some potential horizon future tests. Because you're right, it's an enormous concern for patients that they are unable to communicate with us, and yet are feeling these senses of air hunger and breathlessness. So a wonderful way to finish up this collaborative idea of suggestion and an outcome. And on that end, I'd like to thank all of the speakers and all of the national chairs and my co-chair, Professor Rush, for this really great session. I hope at home that you've found it useful, that you've learned something, and thank you for participating in this really great session.
Thank you.
Thanks,
Bye-bye,
everybody.
everybody.
See you.
Thank you.
Thank you.
Bye-bye.
Bye. Thank you.